Welcome. In this explainer, we're going to take an evidence-based look at the controversies surrounding syndesmotic screw fixation in ankle fractures. Our entire analysis is grounded in the systematic review by Peake and his colleagues, and we'll be critically examining the data that really challenges many of our current surgical practices. Now, we all know screw fixation is pretty much the gold standard for stabilizing these injuries. But let's be honest, there is significant variation in how we all do it. This lack of consensus points to a real clinical equipoise that we need to address. So, let's dive into the evidence. A survey of UK consultants really highlights this lack of standardization. I mean, look at these numbers. We're nearly split on cortical purchase, we're all over the map on screw size, and there's major disagreement on post-op protocols like screw removal and weight bearing. This uncertainty is precisely what this review aims to clarify. So here's how we'll break it down. We'll start with the core clinical questions, then look at the evidence for screw diameter and number, followed by cortices and position. Then we'll tackle the big one, the removal controversy, and finish up with some solid, evidence-based recommendations. Okay, first up, the core clinical questions. We're going to start by breaking down the key variables and really defining the clinical uncertainty that's driving all this variation in our techniques. At its heart, this uncertainty comes from a fundamental challenge, trying to translate biomechanical data into predictable clinical outcomes. We often assume that a mechanically stiffer, stronger construct must be better for the patient. But as we're about to see, the clinical evidence doesn't always back that up. All right, section 2, screw diameter and number. This is where we get right to the heart of that debate between biomechanical strength and what actually happens with our patients. Now, this slide is where things get really interesting. There's a clear disconnect. On one hand, biomechanical studies are consistent. Bigger screws and two-screw constructs are mechanically stronger, no question. But when you look at the clinical studies, that mechanical superiority just doesn't translate into better functional outcomes or preventing malreduction. But here's a key clinical point. While functional outcomes might not change, hardware integrity certainly does. This data from Stewart and colleagues shows a very clear trend. Now, it wasn't statistically significant in their study, but you can't ignore it. The bigger the screw, the lower the breakage rate, all the way down to 0% for 4.5 millimeter screws. And that has direct implications for hardware failure and patient morbidity. Okay, section 3, cortices and position. Let's get into the tricortical versus quadricortical debate. We have to ask, does grabbing that fourth cortex add real stability or just potential complications? The prevailing logic seems to be that engaging four cortices gives you a more robust fixation. It just feels stronger. But as surgeons, we have to ask, does the evidence, both in the lab and in the clinic, actually support that feeling? Well, the data is pretty clear. Multiple cadaveric studies find no biomechanical advantage to that fourth cortex. Clinically, a meta-analysis actually found better early functional scores in the tricortical group. And what's more, quadricortical fixation comes with a higher complication profile. We're talking increased risk of syndesmosis and irritation or even rupture of the posterior tibial tendon from a prominent screw tip. And that brings us to section 4, and maybe the most contentious part of this whole topic, the removal controversy. The clinical literature here is just remarkably contradictory. You'll find studies supporting every side. But the most compelling piece of data is also the most paradoxical. The patients who report the best functional scores are the ones whose screws broke and were left in place. This strongly suggests that after the ligament heals, restoring some of that physiological motion at the syndesmosis is a good thing for the patient. This finding really forces us to challenge our own rationale. I mean, if a broken screw, which essentially creates a dynamic fixation and avoids a second surgery, is linked with the best outcomes, why are we routinely subjecting patients to another procedure with its own set of risks? Because let's be very clear, routine removal is not a benign procedure. The data from Scheppers and colleagues shows a pretty significant complication profile. We're talking a nearly 10% rate of wound infection and a notable rate of recurrent diastasis. When you add it all up, the complication rate approaches 20%. That's a number we simply cannot ignore. So, on to our final section, recommendations. After looking at all this data, we can now synthesize these findings into a pretty pragmatic guideline for our surgical technique. So here it is. This step-by-step approach represents the technique with the strongest evidence base right now. A single screw is sufficient, a 4.5 mm diameter minimizes hardware failure, tricortical purchase avoids those medial-sided complications without losing stability, and finally, selective, not routine, removal avoids the morbidity of a second surgery. And this quote really just encapsulates the conclusion from multiple modern studies. The practice of routine removal seems to be a holdover from an era of more rigid fixation, and it's just not supported by the current evidence, especially when you factor in the costs and complication rates. So, to conclude, let's distill all of this down into the key takeaways for your practice. If you remember one thing from this entire explainer, this sentence is it. A single 4.5 mm tricortical screw left in place unless it's symptomatic. It's a simple, effective, and safe technique that's well supported by the available data and minimizes patient morbidity. And this really leaves us with a final, practical question for our entire community to consider. The evidence strongly suggests that a shift in practice from routine to selective removal is warranted. A change like this would better align our standard of care with the data, and most importantly, it would improve outcomes for our patients. Thank you.